Hello, thank you for joining this webinar. It's a great honour and privilege to be here. My name is Peter O'Kane. I'm a consultant cardiologist in Bournemouth, UK. I'm editor-in-chief of ICR3. And I'm here in London with a really distinguished panel and experts. I have Professor Curzen, who's a consultant in Southampton Hospital, just handed over BCIS presidency, which is here at ACI. I've got Thomas R Keeble in the Essex Cardiac Centre, who's a great proponent and leads our out-of-hospital arrest service in BCIS. And I have Nilesh Pareek, who's a consultant cardiologist in King's, who's done an incredible amount of work in this area. And we're joined online by three real experts. It's a pleasure to have Dawn Adamson, who's a UK colleague in the Midlands. I've got Roxana Mehran from New York, who doesn't need any introduction as a world authority in interventional cardiology, and Marco Noc, who has really understood and has revolutionised how the European approach to out-of-hospital cardiac arrest. So we're going to have some great discussion. I'd like to start by asking Professor Curzen, why and how do you think the UK has had to try and standardise our out-of-hospital cardiac arrest pathway?
So I think there's an awareness that this category of patients is treated in a very variable way in the UK, and it's particularly troubling. As interventional cardiologists, it's very difficult to get accurate data about patients who are not treated aggressively. We tend to have to use surrogates from our databases that involve whether people go to a catheter lab and have an intervention. And of course, those type of data are extremely inaccurate if you want to see what's happening to the population of out-of-hospital cardiac arrest patients as a whole. But we have published a couple of papers that show very clearly there's an enormous heterogeneity in the way these patients are treated, and quite simply that can't be right. Either too many people are being treated very aggressively, or in some centres not enough are. So we got interested in this, and I guess one of the things that became obvious is that there's a lot more to it than just the catheter lab. And what we have tried to do and focus on for the last few years at BCIS is to look at how we assess the patients and why we make the decisions we do about them. Ultimately, of course, the most useful thing, and I think thanks to Nilesh and the King's group, we're making great progress on this, is perhaps the most useful thing would be one day that we have a way of communicating someone's chances of survival very early when they come into hospital. In other words, we could identify patients who are likely to be futile to intervene in any way upon, which means that every other category of patients should be seriously considered for very intensive therapy, not just for catheter lab, but in every other way. And I think that's what we've been aiming to do, to try and standardise the way patients are greeted, assessed and treated.
Okay. Tom, where are we currently then in the UK, and how did you kind of come around to organise this new pathway development?
Well, I say, as Nick suggests, there's huge variation, and that can't be right. And so we know currently, and the data, as Nick said, is a little scanty, but approximately only around 50% of all patients with VF and VT STEMI go to a cardiac arrest centre. And we felt that was an unacceptable variance. And so we wanted to try and standardise that. Now, the Resuscitation to Recovery document 2017 and many of the guidelines suggest that all cardiac arrests with a cardiac etiology should go to a cardiac arrest centre. But that model really has not been adopted in the UK over the last 6 years since its publication. And so what we felt we had to do was kind of take this piecemeal. We could not overnight make every heart attack centre take every cardiac arrest of cardiac potential origin, because I think it's fair to say the system would just be completely overwhelmed. And so what we felt we had to do was take a sort of pragmatic approach where we could maybe take the biggest beneficial gain patients to a heart attack centre, cardiac arrest centre, to give them the best possible outcome. And so I think it's fair to say it's a pragmatic algorithm. It doesn't take everybody, but we feel that we know asystole and PEA cardiac arrest causes do 50% of the time have a non-cardiac cause. We also know that the PEA asystole patients do much worse, with a 80 to 90% mortality rate. So it just felt intuitive and pragmatic that if we're going to bring in the type of patients to the cardiac arrest centre without overwhelming all of our centres, then the way to do that was to be pragmatic and take VF, VT and STEMI. And we accept there are limitations upon that stance, but at the same time we felt that that would give us the best, if you like, bang for our buck with regards to resource implications. Not only that, but this algorithm we have derived is also simple for ambulance crews and pre-hospital care teams, and actually that's what they're crying out for. And when we actually went to our pre-hospital teams and said, tell us how this is going to work, they wanted something very simple, and we believe we've made that. And so we hope that on the basis of that we will come up with we have come up with an algorithm, and we are already piloting it, that we can take data and we can deliver good results. And the most important thing, I guess, is then auditing our results and ensuring that it's having the desired effect on patient care and patient safety and standardisation.
Well, we're super grateful that you worked collaboratively with BCIS and the focus group and published it in the journal, because I think it's really important. And we'll come back to you about your sort of the data you've collected already, and we'll ask you about that later. Nilesh, moving on from that, sort of definition of what a cardiac arrest centre is, Tom's touched on it, but could you sort of define it in a more way that might be applicable to other people to understand?
Yeah, thanks, Peter. As a group, we were quite keen to define a cardiac arrest centre quite early. We know that the AHA and ESC have also defined it, and we were largely in agreement with their definitions. We were also clear that we wanted really for the cardiac arrest centres to be modelled quite closely on the heart attack centres, the traditional heart attack centres, because many of the skills are already there, and also the networks are all in place and quite well established. So, what we really did was take the services of a heart attack centre, and in many ways mandate an assessment which will come onto a sort of uniform assessment within that structure. So, in brief, some of the clear principles of the cardiac arrest centre are 24/7 primary PCI, specialised echocardiography. You may call it basic mechanical circulatory support with balloon pump, but then also looking forward to specialist ITU care, and then also rehabilitation. And then in the future, as cardiogenic shock pathways develop, there are likely to be super specialised ECMO transplant centres that will feed into that, and that's probably going to be the next arm of our work.
I think a very important component of this, in principle, is that you have to have a champion who's interested in doing the best for these patients in each centre. So you have to have a champion in the emergency department. You have to have an intensivist who's a champion for these patients, and the cardiologist at the very least, because one of the issues about variation in practice is that on a Tuesday night in December, you may have an ED doctor who's not particularly interested in these patients and doesn't realise how much we can do for them these days, a cardiologist who's not that interested in out-of-hospital cardiac arrest, etc. We need to eliminate that possibility. We need to raise our game in terms of how these people are greeted and assessed, I think.
And do you think every centre has capability to be like this, or are we only going to see that situation in selected centres?
I think most centres that provide 24/7 primary PCI tend to have an infrastructure that would be suitable for this. But again, for me, it comes very much down to, can we engage people to be champions and up the game in terms of the quality of the assessment that they provide very early on. I think, for example, in our field, interventional cardiology, many people who are on call when they get a phone call about an out-of-hospital cardiac arrest patient who's just arrived in ED, if they haven't got ST elevation, thanks to the randomised trials, they will quite happily say, not for the cath lab, roll over and go back to sleep. Well, if we want to improve the outcome of these patients, I don't think that's going to be an adequate response in a lot of the cases.
Nilesh, could you tell us a little bit how you're going to assess these patients as they come through the door?
Yeah, thanks very much. Nick mentioned that we're really keen to have an MDT assessment on arrival, and we think that will also help us standardise the assessment of the patient. So we felt quite strongly that there should certainly be an interventional cardiologist on call, the critical care medic, and if there's an ED on site, also the emergency department team assessing the patient together, because they may have their own insights within their field that could be very useful. There's also been a huge step forward in our assessment of the cardiac arrest patient over the last few years. Previously we were using quite poor tools, downtime, age, ECG, which can be quite a poor predictor. And we've all been collaboratively working on risk stratification tools. So the Miracle 2 score, which is a very objective predictor of neuroprognostication. The Sky shock grade, which is recommended by many consensus statements and also by societies. Echocardiography, blood gas, and I think once you put those all together, you're getting a better picture of the patient, and you're in a much clearer position to treat them properly. So I really feel this is one of the cornerstones of our consensus statement. Is if we don't assess them, we won't be able to treat them properly. So we feel that's a cornerstone of the statement, that every patient should get that as a minimum, and then we can move on and understand the patient better as we move forward.
It makes complete sense to me. I'm going to bring in our online panel so that we can sort of generate a bit more discussion. So, Roxana, if you don't mind, I'll start with perhaps with you and Marco to each give some comment, because you both very kindly obviously read the paper and you wrote a very nice joint editorial. So maybe get your comments on the pathway itself, on how it applies in the UK, and maybe how it applies from an international perspective.
So if I can start, I think I wanted to just congratulate the British Cardiac Society, Interventional Cardiac Society, for BCIS, for actually putting forth this very important statement. Standardization is key in order for us to be able to all speak the same language and be able to assess patients in the same way, treat them equally, and then, of course, bring them forth and hopefully give them the best chance of survival. And there's no other place than the out-of-hospital cardiac arrest, where we've seen so much variability, not just in the UK, but all over the world. I think the statement puts the consensus work that's been done by our UK colleagues set a great standard for everyone else to follow. Having these organized cardiac arrest centers will be key in assessing these patients in a very, very good way. We are all very much aware of the early assessment and early resuscitation and the evaluation of these patients. Some of these patients are getting lost and obviously not being given the best chance possible. And I think I'm very, very supportive of that particular statement, especially in light of understanding that this is a multidisciplinary approach, and they very well defined the cardiac arrest centers of what are some of the key factors of evaluating these patients that I don't think that is actually happening around the world in a very standardized way. So I congratulate you all, and I believe it's a great way forward for all of us to speak the same language. And here in the US, after we saw the Monday Night Football and that early resuscitation with the use of AED has really put this on the mind of, wow, this really happens. And a picture is always worth 1,000 words. Here's a person completely active, making a tackle and then going down. Now, that was a separate situation, obviously, but again, very, very important to have that early resuscitation, AED on site, et cetera, and then upon evaluation to give everyone their very best chance. So I applaud our British colleagues for putting this forth, and I was honored to be able to work with my colleague, Dr. Noc, to be able to give you a little bit of a commentary on it.
I join, of course, Roxana with the congratulations. I think this is really an important step forward, and I feel that patients with out-of-hospital cardiac arrest are too often forgotten orphans of interventional cardiology. I strongly believe we can do quite a lot, but we have to select patients carefully. And that's what you exactly did. You implemented the recent randomized trials, and also the important work of Nilesh and Phil, and we were so lucky to join him with the Miracle 2. I think these are very, very important new developments to tailor our approach, our interventional approach, so to say, to the patients with out-of-hospital cardiac arrest. And I join Nick, and I fully agree that we are probably in a stage where we were before we started STEMI network. And probably the easiest thing, and what we did also here in Ljubljana in Slovenia many years ago, is somehow to merge the care for the auto hospital cardiac arrest with the STEMI network and admit them to the same institutions. Of course, I admit there are different patterns, different countries, different geographic features, and we have, of course, to respect that and tailor our approach and guidelines, local guidelines, national guidelines, if you want, to the real-time situation.
Thank you very much. And Dawn, with your new role, do you welcome this approach and the guidance to sort of help maybe create this more streamlined pathway, as Nick has alluded to?
No, absolutely. So I think within my role as well, what we want to be doing is streamlining the whole pathway. So I think we're going to be working quite a lot with our system partners to try and improve access to really high quality basic life support. And as Roxana was saying, AED, particularly now that we've had information from Department of Health that all schools are going to be offered AEDs, hopefully to the outside of them and not inside of them, so that they're accessible. And I think the important work that the BHF has done on the circuit to actually map all the DFibs across the United Kingdom and make that those DFibs accessible to basic life responders, first responders, because the more that we can do to get the patient arriving at the centre in the best possible quality, having had really good quality basic life support, I think is really important. And then taking the work forward that you're doing is absolutely key. So yeah, completely, fully support it. And I think it's about really trying to work on the whole pathway from beginning to end. So I think, again, the work that Tom and the team are doing in the post-recovery, I think, it's a huge area that is both under-resourced, underfunded, and certainly we need some work on how we improve rehabilitation within the UK and access to rehabilitation in the UK post-cardiac arrest. So it's a new role that I've only taken on a couple of weeks ago, but really looking, forward to sort of both, doing the work that we're doing at BCIS, but also looking at either end of the pathway and just trying to make sure that all that really good work that goes on in ED and the cath lab then comes to fruition to make sure that the patients have the best possible outcome from a functional point of view as well.
Fantastic. I mean, I think we'll touch on the rehabilitation and the psychological aspects for the survivors. I think that's really important. But before we do that, can I just hear from both of you, all three of you really, about the data? So the pathway is obviously now in print, but you've been doing this type of work before. You've set up a great service and you've done all the scoring. So just tell us a little bit about the data collection and how you plan to sort of monitor that.
Yeah, so the BCIS has now got a registry, so a web-based registry, which we are piloting in Essex just because we wanted to pick an area that has a fairly mature system so that we can get the data before the algorithm, and we've collected data with ethical and CAG approval from April through to October. And we've looked at that as our kind of baseline. And then we have gone from the middle of October, after significant training to the ambulance crews, from the middle of October, we've taken on the new pathway in line with the consensus document. And again, we've then audited that data, and I'm delighted to say we've got the data back already up until December. And what we show is that before the algorithm change, we took 40% of VFVT and STEMI from our local population of 2 million. And with the algorithm change, we've now driven that up to 60%. And so we think that can only be a good thing. With that 60%, we also know that in that there were 22 patients in this 10-week period, all of which went to the catheter lab and had angiography because it was deemed appropriate. Half of them required percutaneous intervention. and about 15% of them in the end had a non-coronary diagnosis and had an ICD. And I think it really just enriches the population of the patients that we want to see. And our survival in this extremely short period of time has gone from 45% to 55% in that short period. But let's be realistic, it's a very short time period with a very small group of patients, and we need to be very, very objective and honest about that data. But I think the most important thing is that we monitor that data and that we are transparent about that data, because we also want to understand, okay, the patients coming to us are doing fantastically, but let's ensure the patients going elsewhere are not missing out. And I think that was a very fair comment from both Marco and Roxana about the PEAs and the asystoles. Yes, we're not taking those routinely, but we need to make sure that they're not getting a real rough deal of this. And we know that in the algorithm there is a crossover. You can cross over from the paramedic, you can cross over in the ED. And I think that's really, really important, because, you know, there are those patients who will have a PEA arrest that have got a left mainstem occlusion, and the only way they're going to get better is having that fixed. But there is an ability to cross those patients over, but we believe that group of patients is a modest number, but we need to be honest and open, and we need to measure that. And so I hope that the way in which we're collecting the data so much better now will allow us to transparently do that.
There are some bits of this pathway which are deliberately left grey. As Tom told you, in the pilot, the rate of immediate coronary angiography or very early angiography is high. And I think that reflects the fact that people who are extremely interested in this area tend to be quite aggressive about looking at the coronaries early. Of course, there's a prevalent view that because of COACT and Tomahawk, you don't need to take someone to the cath lab, and you maybe even shouldn't. Neither of those trials showed any harm in doing an early angiogram, and of course there are some real advantages to knowing what the coronary anatomy is like. If the coronaries are unobstructed, that's an incredibly useful thing to know when you're looking after the patient when they're in intensive care. And if you do find a blocked artery, which of course you often do without ST elevation, it's likely, if it's an acutely occluded vessel, to help the patient's outcome. So although the randomized trials suggest that we don't need to take people to the cath lab if they don't have ST elevation, I still think there's a role for early angiography, and it tends to be that people in this type of situation have a lower threshold for doing that, which can be very helpful, I think.
I think it's a good point. It is one of the controversial areas of the guidelines, isn't it, for sure, because a lot of colleagues thought they could stay in bed and not treat these patients.
Well, I think, to be fair, the concept that we have an MDT, I don't necessarily think that the interventional consultant who in the UK and like in the States, I think, is not on shift, so they will be doing a day, night, day pattern of work. I don't think they necessarily have to come in as an emergency to see the patient in person to do an MDT discussion about making an initial plan. But in many situations, of course, because you're coming in to do an angiogram, you will be able to assess the patient. The key is having experienced, well-motivated experts coming to a consensus about whether a patient is futile or not. My concept for BCIS is that one day we will set limits with the help of Miracle 2, etc. And if a patient doesn't fall in a threshold that we all agree is futile, then we will be able to audit our colleagues as to why more action wasn't taken if they weren't futile. Now, in many cases, it will be entirely appropriate that they didn't do more. But on the other hand, it will allow us a baseline to cut out the variation where it appears from our crude data that some interventionists are just not taking these patients at all, and some of them are taking huge proportions. So we need to iron that out.
I just had two brief comments. One is that we've looked at the percentage of patients that would meet COACT and Tomahawk, and even within the without STEMI patients, only 40% would have met Tomahawk, and it's even lower for COACT. So I think it's really important not to over-extrapolate that randomized controlled trial population. For example, hemodynamic instability was a clear exclusion in those studies. So we have to be careful about over-extrapolating that data. And the second brief comment was, really very grateful to Marco and Roxana's comments in the editorial. We spent a lot of time thinking about PA and asystole, and really, we saw this as an iterative approach. I mean, we felt that bringing the shockables to the centre was an easy win. And, that was to us, seemed like a very clear step to get them to a centre without overburdening the heart attack centre teams. But we will be very closely auditing that. And We also await the arrest trial data, which we expect later this year, the UK arrest trial, I may call it, which we expect later this year, and that will certainly inform our future guidance also.
I think you see that's such an important point, because you have to take into account that many of our colleagues may not be quite so keen to adopt this strategy, and to have included non-shockables in the algorithm early on may have probably disenfranchised some of the people who currently are not quite so keen as we are to do it. So we deliberately and, possibly slightly cynically have gone for a group of patients where we think we can make a big difference and demonstrate a big difference.
No, I think you're right. I think you go for the early wins, get the adoption, and then gradually you can build things through. I mean, you both, Roxana and Marco, you did point to that in the editorial, but does that sort of discussion we've had, ease that discussion for you in terms of how you feel?
I think it's a very relevant discussion. I mean, these are the problems we are faced with. Importantly, in comatose survivors of cardiac arrest, the cause of death is related to the post-resuscitation brain injury in 70%. So basically, we are dealing with 30% we can influence, we can decrease. And I think what is really important, and what has been developed by Nilesh and Phil McCarthy group, the Miracle 2 score, which, and I'm sure, in the future, this will be further refined. We can decide whom not to take, which patients are unlikely to wake up, because then the care is futile. I mean, whatever we do, all the BCIS, all the hemodynamic support, it will not help. It will be very depressing if the patient doesn't wake up. So I think we have to go this direction, really, to select better patients with the potential to wake up. And then, of course, we will see much more rewarding results also, if you want, of our intervention, our immediate intervention.
Yeah, I think that's a really good point. I'm conscious of time, and I think I really want to touch on, the second paper that you wrote. And I've seen some pictures that you've shown at meetings of the group of people you bring back who've had successful resuscitation. Can you just tell us a little bit about that group and about how you manage the mental health and psychological aspects of?
Yeah, of course. So in 2015 we started doing quite a lot of cardiac arrest work, and I started following the patients up, which I'd never done before. And I think I've told this story a number of times. The first 3 patients that came in with their family members all just cried in front of me. I was expecting a bottle of wine and a nice card, and they literally just came in and cried, and it was really pretty upsetting. So on the basis of that first ever clinic that I set up, I then knew I had to roll something out more quickly, and so we made it a standard of care. And there is some nice data, and it's in the guidelines, but it just seems that a lot of people don't do it in a lot of centres. And part of the trouble is identification of patients. I know it sounds crazy, but these patients often, especially actually the ones who are not comatose, so the ones that have a cardiac arrest, then have a quick shock, have a STEMI, go back onto the ward, we discharge them just like they're any other STEMI, and actually they're clearly anything but that. And so we used to miss those, we now don't miss those, and so they have to get, obviously, of course, cardiac rehab, but also the psychological and counselling support that goes with that. And we now have a specialist we call care clinic, care after resuscitation clinic, which sees the patient within the first 3 months and at 12 months. And again, we've refined this clinic over the last 5-6 years. We had the biggest patient group in the world called Sudden Cardiac Arrest UK.org, which is the most incredible group, and everything that we do is driven by them, because it's really easy. If you ask the people who are suffering with this, they will tell you what they want very clearly, and they want some support, some guidance, some rehabilitation.
And you're ready to roll that out on a national level? Because it sounds like we all need that sort of...
The thing about this is it doesn't need to be expensive, genuinely, okay? So we've got armies of rehabilitation nurses in all of our centres, in all of our district general hospitals, who are paid to rehabilitate patients. We're talking probably about 1 to 2 cardiac arrest survivors per month, in addition to your standard, what you've got. What we want to do on the basis of ours and others' experience is roll out a more specific cardiac rehab, so that the rehab nurses via the BACPR network are trained a little more specifically in the nuance of cardiac arrest survivorship and the family problems that go with it, driving, defibrillators, travelling, working, etc., all of those massive amounts of psychosocial issues. So I think it's pretty straightforward, but maybe I think that about most things. And I think what we've got to do is upskill the people that are already in place, that are already on the payroll, but allow them to explore these patients and follow up these patients with the skill sets and the people that we already pay. So it doesn't have to be costly. Where it might be more costly is the neuro rehab that we don't have. We are really lacking in neuro rehabilitation slots for the more injured patients for in-hospital. If you go to Holland, they have hospitals just for neuro rehab. We really have few and far between places, and our patients generally who are badly brain injured wait months before they go. And we know that often the earliest phase of the brain injury is where they stand to gain the most. And I think we do our patients a disservice.
Brilliant. And I guess, Dawn, from your role now, that's something you're going to be very keen on. You mentioned it before, but from a sort of national level, pushing for this, making sure that these algorithms are in place for all patients in the United Kingdom.
I mean, absolutely. It's something I'm going to be working, with as part of NHS England. But as you can imagine, unfortunately, the role doesn't come with a large pot of money. So it's about really getting the evidence both for the sort of success, both, functionally, mentally, and having that information and data that can then drive the fact that, yes, these are areas that we are failing, and to then try and drive, with the out of hospital cardiac arrest expert advisory group, which I'll be chairing, Department of Health and NHS England to look at how we fund this, because I think there is an absolute, huge need, and a need that, as Tom was describing, I've seen as a clinical interventionist here in the Midlands. It's something that we're all sort of seeing, but somehow we're blinded to initially. It's something I hadn't really been thought of until, some of the earlier BCIS out of hospital cardiac arrest study day that I went on, which sort of opened up my eyes. I think I was very focused on the sort of, within the cath lab, initial assessment within the cath lab, ITU type management. But actually, I, put my hands up and said, I think I'd lost track of the whole journey, from beginning to end. And it's now really starting to see not just what we do in the cath lab, but the beginning bit of the really good basic life support, so that there is a brain that's alive and worth, resuscitating and working on, and then that bit at the end. So absolutely, I think it's the whole end-to-end pathway. I just can't promise any miracles in the next few weeks, months.
Some of the rehab for survivors and their families is probably within our power to reorganise services to help focus them. But the other group that I would highlight are the young patients who have brain injury that requires proper brain injury rehab. And in a lot of big centres like ours, we have very advanced stroke rehab for people with brain injury, and we're not allowed to access that specialist team for people who have hypoxic brain injury for out-of-hospital cardiac arrest. And it's got to a level that I would describe as disgraceful, because I had a 44-year-old man who had hypoxic brain injury, had made a fantastic cardiac recovery, and we weren't allowed to access any specialist rehab service while he was an inpatient, even though there's a team that does exactly that for stroke. So we need to really keep our eye on that, because it's just basically not fair.
I agree. I mean, it's I think in many senses it's forgotten. I think sadly. There's a very good advert for the out-of-hospital cardiac arrest study day, which hopefully you'll be running this year, because I think that's a fantastic resource and get more people motivated in this area. I'm conscious of time. I think we've probably come to the end of the session, but I'd like to just open the floor for anyone who wants to say any further comments.
Can I just make a little plug for people to think about the Good Sam app? So the Good Sam app is an app which basically alerts you to having that if there's someone having a cardiac arrest within the vicinity of where you are. We know that a significant number of cardiac arrests happen at home, and obviously, particularly at the moment with the ambulance delays that we're experiencing in the UK, that actually, if someone has got urgent and immediate good quality CPR, that their outcomes are a lot better. And one of the things I'm doing is working with the team at Good SAP. We've got a lot of basic life support, first responders that are on the app, but we have a huge resource of NHS staff who are trained in CPR, have regular mandatory training. And I think if we can start actually encouraging our own teams to turn on that app, and you can turn it off. It's not, you don't have to be on 24/7. But I think that would be a really good resource to start improving sort of basic survival into hospitals for us to work on.
Wow, that sounds really ingenious. Actually, really clever. So I'd like to thank everyone for coming. I was going to special thanks to Professor Curzen because, as usual, you had this insight to create the focus group. You knew exactly who to put into the focus group, and you've developed this incredible pathway. And I think we're grateful. I think the patients will be grateful, and it's a great legacy. And thanks to Tom, thanks to Nilesh, thanks to you online, Roxana, Marco, and Dawn. It's been a great session. I hope you've all enjoyed it. It's a lot more to this. Please read the papers, part 1 and part 2, and the editorial. Make up your own mind, and from the sounds of it, download the app because that may save a life. Thank you very much.